Welcome everyone to the special collaboration between the Neurospecialist Institute and Saebo. My name is Michael Ang and I am an occupational therapist and a certified neurospecialist. I'm so thrilled to be with you here today, and this presentation will be about utilizing a mixed method approach when it comes to neurorehabilitation. So I'd like to introduce you a case, and this is about Mr. Kim, who was a 65-year-old man who had a stroke 2 years before he started occupational therapy. I actually meet him by accident. Mr. Kim didn't have an order for OT, he had an order for speech therapy. However, I do a screen with him, and I believe that Mr. Kim could benefit from OT, so I request an order from his doctor. I call up the doctor and we have a conversation, and eventually the doctor says, you know what, no thanks. I don't think he's gonna need OT because what's the point of doing arts and crafts? Mr. Kim doesn't have a mental illness. Oh gosh, so there's a bit of a disconnect because it seems like the physician only saw OT from the perspective of moral treatment, OT as the profession that does arts and crafts and so on and so forth. So I move on to the neurologist. I call up the neurologist and I ask him for this order, but the response wasn't encouraging either. The neurologist says, Mr. Kim had a stroke 2 years ago. He had physical therapy for the past 2 years to work on his hand. The problem is physical therapy never fixed his hand. So what's the point of OT? At this stage, OT would be redundant. So another point of disconnect, because the mentality here is if we can't fix the hand, if we can't fix this part, then we can't fix the problem. What's the point? So then I asked the neurologist, what about the importance of occupation? What about the importance of meaningful activities, returning to work? And the response was, it's been 2 years, his rehab potential is poor. And at this point, I just about lose it because this is a conversation I'm having with the neurologist, and he should be well versed when it comes to neurorehabilitation and cortical changes. So I tell the neurologist, if you have a patient who's active and engaged and acquiring different skills, his brain is reorganizing and adapting towards proficiency for those skills. Is that correct? And he answers yes. However, if Mr. Kim is sedentary and becoming more dependent, it's not like nothing is happening to his brain. In fact, his brain is still reorganizing, his brain is still adapting, but instead of towards proficiency, it's adapting towards dependency. Is that also correct? And the neurologist, again, he says yes. So, you know, we have this conversation about neuroplasticity, and eventually I asked the neurologist, doctor, do you play any sports? And he tells me that he plays baseball. And I tell him, well, I assume you're better at baseball now because when you first started playing, maybe you're a little bit clumsy, you're working on your motor skills, etc. But now, after years and years of practice, I assume you're much better. And he answers yes. So as you practice, you experience all these cortical changes in your brain that makes you a better baseball player. So then eventually I say, doctor, your occupation is baseball. Mr. Kim's occupation is also baseball. So please, please let him have occupational therapy so this man can play some baseball. And the neurologist was like, oh my, you know, I didn't really think about it that way. I can't allow this person to not play baseball. So we end up getting the order from the doctor. I go back to Mr. Kim and I say, Mr. Kim, I really hope you like playing baseball. I don't even know if you do because I made that part up, but the doctor is giving you therapy because he wants you to play baseball. And lucky for me, Mr. Kim actually loves baseball. So this was just fantastic. So I'm going to play a few videos demonstrating this mixed method approach, and I'll play each of these videos twice, the first time without any commentary so you can observe the patient's movements, and then I'll replay the videos with my commentary. So this first video you're going to see is Mr. Kim's movement at evaluation, and I want you to look carefully at the motor control and think about some of the major problem areas.
가까이요. 분목, 분목 좀 하세요. 손목을 피세요. 거기서 피세요. 손목을 밑으로.
So once again, this is Mr. Kim's first day in occupational therapy. This is his evaluation. We're going to take a look at his grasp and release here. Having quite a bit of difficulty there with just coordinating his movements, trying to extend his fingers, not really able to fully extend in order to have a good grasp on that ball. Coming over the top here, trying to do a spherical grasp. And if you're wondering why we have him constrained, the reason for this is essentially because every time we're asking him to move, he has a tendency to move his non-affected side. So we're hoping that if we put that in a constraint, that he can spend a little bit more energy and effort and I guess mental capacity focusing on that affected side. So right now we see that he's able to come over the top and trying to do this spherical grasp. Doesn't seem too bad at this point, but as we continue on with the video, he sort of loses his grip here. And right now I'm going to take a pause here and you can see that he's holding onto the ball, but the ball is not resting deep inside the palm of his hand. Instead, the ball is hanging out a little bit more distally. It's really his more distal joints going into flexion that's holding the ball in place. So not a very functional type of grasp.
손목을 밑으로.
And when we ask him to release the ball, he's not able to actively extend his fingers, unfortunately. So what he's doing instead is he's squeezing the ball out of his hand. So he's using his finger flexors in order to release the ball instead of actually releasing at his fingers for extension. So one of the main things I want you guys to start thinking about is what is normal movement and what is functional movement? And do they really differ and should they differ? Because a lot of therapists might see their patient do something like this where they can actually pick up the ball. Doesn't seem like it's a very functional type of grasp. However, they're still able to do it, although it's very compensatory. So the thing is, not everything that is compensatory can be functional. If Mr. Kim wants to play baseball, holding a ball like this isn't going to really do any good in the long run because he's not able to actually hold this position for a very long time. He's not able to actually throw the ball from this position either. So even though we can see that he has some motor control, we have a lot of work to do in order to get it to the point where he can be truly functional, where his movements can be quite a bit more normalized. In this second video, we have Mr. Kim move his arm in a certain position. So before we watch this, I want you to really think about how is his entire arm positioned as he's seated in this chair. We have his arm elevated, we have it supported, but take a look at the actual body mechanics in terms of what's going on with his shoulder, what's going on with his wrist and elbow. So in this next video, one of the first things you're going to notice is that Mr. Kim is doing flexion and extension here at the wrist, just warm-ups here, just to see how his fingers and hand is moving at the same time. You notice there once again that every time we're asking him to move that affected side, that right arm, he has a tendency to move his left as well. So after that, we constrain him once again. We want him to focus entirely just on his right hand. He's having some difficulty here with abduction and extension of the thumb. So we have our therapist assisting with that passively, trying to get a nice smooth motion. So why are we asking Mr. Kim to just focus on wrist flexion and extension? Well, basically what we're trying to do here is Mr. Kim is using tenodesis for finger extension, just regular biomechanics. What can our body already do in terms of the muscles and the tendons that we have in our hand? With wrist extension, you're going to get natural finger flexion. And with wrist flexion, you're going to get natural finger extension. So how do we use this natural and very normal type of movement to our advantage? Well, essentially, we have him in this gravity-assisted position where we have him practicing wrist flexion and extension just to see if he can get some finger extension as well. So every time he's going down into wrist flexion, we see that he has quite a bit more finger extension, and we're trying to utilize that to our advantage. And we're trying different types of grasp with him to see if he can actually extend his fingers to release this ball. So we don't want to just work on a spherical type of grasp. We want to work on pincer grasp. We want to work on a three-jaw chuck, as you're seeing him do here right now. Still having a bit of difficulty with finger extension to release that ball, but not too bad. So taking a look here once again, Mr. Kim has excellent finger flexion. His finger flexion is his own, it's volitional. He's using that active motion in order to grasp the ball. Now, when it comes to releasing the ball, he's having quite a bit more difficulty. So one of the first things we're asking him to do, go into wrist flexion in order to help facilitate that finger extension to release the ball. Okay, nice release there with that finger extension. The other thing you're going to notice here as I pause this video is that Mr. Kim actually has some tape on his hand. Contrary to popular belief, this is not kinesio tape. This is actually something called dynamic tape. Dynamic tape works very similarly to kinesio tape. However, it tends to have quite a bit more of a stretch, quite a bit more elasticity. So if we wanted to pull him towards extension quite a bit more, you're able to do so with dynamic tape. Having some difficulty here with that release. Even though he's going to some wrist flexion, he's not really able to go into that extension of the fingers. Starting to feel some tightness here. He has to stretch it out, spasticity kicking in. Now, one of the main things you're also going to notice here is Mr. Kim is seated with his arms supported. And you might think that the reason why we're trying to do this is to provide that proximal stability in order for him to have quite a bit more distal mobility, which actually is true and it can be helpful, but that's not really the main intention here. The main intention here is to train Mr. Kim to move his finger and hands while he's close to a flexor synergistic position. And when I mean flexor synergistic position, I'm talking about what this looks like. Some people get confused. They think that this is flexor synergy, but flexor synergy is actually up here in its most pure form, meaning that the shoulder is flexed and abducted to about 90 degrees. You have some external rotation here, as well as elbow flexion, and you also have flexion at your wrist and your fingers. So to clarify, once again, this is what flexor synergy looks like, not down here. Now, the way that we have Mr. Kim positioned is that he is not in pure flexor synergy, but we've gotten rid of that external rotation because we found that he's better able to actually move his hand down here versus up here. And so that's really the first reason. The second reason is because we didn't want him to become proficient in moving way up here. We wanted him to actually come a little bit closer to his center and his core, a little bit closer to midline, because you're going to do functional activities down here. You're not going to do them up here. So we're really trying to transition him away from this flexor synergy back down to this plane. And I'll talk about why training in synergies can be useful a little bit later on, but you might notice that quite a few of your clients are better able to actually move their fingers, move their hands, move those distal components if they're positioned in flexor synergy or extensor synergy versus if they were position in some other type of position. So we wanted to do a movement analysis with Mr. Kim, see where he's best able to move, try to position him in those areas, which we call positional training, and try to let him become proficient. And eventually we're going to wean him off those positions into something quite a bit more functional. So once again, you can see here with flexor synergy combined with tenodesis, able to flex and extend those fingers. Not entirely functional, but this is essentially our first intervention that we did with him with a movement analysis, just trying to see how well he's able to move in order for us to optimize his program. So the next thing we do is we try out different orthotic devices. And one of the first things that we've actually tried is this photo here of a dynamic extension orthotic device. And this one in particular is used for radial nerve palsy. So I have this device on my hand, and what you can see here is I'm going to use my own volitional movement to go into finger flexion. And now I can grasp something. And what's facilitating extension here are these outriggers and these springs to pull me back into finger extension. So if I were to actually grasp something here, I'm using my own volitional movement in order to do that. And in order to release, all I need to do essentially is to relax, and the mechanics of this can pull my fingers back into extension. However, one of the first things you're going to notice is that the finger loops are not as distal as it potentially could be. So what's happening here is that these loops are crossing my DIP joint. So if I go into finger flexion at my PIP and DIP, and this pulls back, what can actually happen here is that my DIPs are stuck in flexion. So even though my PIPs are extended, the DIPs themselves are still in flexion. So what can actually happen is I'm now stuck in this hook type of grasp. Instead of going into full extension, I'm stuck here. So this type of device didn't really work out for Mr. Kim. So we wanted to try something out that was better for him. So let's take a look at this next video where Mr. Kim is wearing a Saebo Flex device. So now Mr. Kim is wearing a Saebo Flex. I wish we actually had a device that was his perfect fit, because this is what we had available to us in the clinic as a trial type of device. But I think he probably would have had better performance if he had something that was directly measured for his digits. But still not all that bad. He was actually able to use his own flexors, his own finger flexors, once again, to grasp this tennis ball. And in order to release the tennis ball, because he doesn't have that active volitional movement to do that, the device itself is trying to facilitate extension here. So having a bit of difficulty, he's kind of shaking about here, but eventually the pulley system in this device is actually able to get him into extension. Here we didn't really see that too clearly. He was essentially just squeezing the ball out of his hands once again. But as he's trying to pick up this ball, once again, using his own finger flexors, and now to release the ball, it's a little bit difficult to see from this video, but all he really had to do was just to relax his hand, and the device itself will naturally bring him into finger extension. So there's just that relax, and that's all he really has to do. He doesn't have to go into too much active finger extension himself. He just has to relax his hand. The device does the work. So one of the benefits of a Saebo Flex device is that you have these digicaps, and the way that they work is I can put my finger through here, and the facilitation of extension is going to be at my most distal joint. So I'm not going to have that hook grasp that I'm going to get with a radial nerve palsy splint. This can actually facilitate quite a bit more extension, especially at the DIP. So you saw what Mr. Kim was able to do here. Part of the issue that he was having as well, it was that with these Saebo Flex devices, they bring you into wrist extension about 15 degrees. Now, whenever Mr. Kim goes into wrist extension, he actually has quite a bit more difficulty in terms of finger flexion and extension just with volitional movement. He's actually much better able to move his hand if he's in a more neutral position. So unfortunately, with the Saebo Flex device, bringing him into that wrist extension, it didn't really facilitate as well as maybe another type of device. And that other type of device I'm talking about is a Saebo glove device. So some therapists today ask me, why didn't I try a Saebo glove device with Mr. Kim? Well, back then, the Saebo glove actually didn't exist. But I think that had it existed back then, Mr. Kim would have done wonderfully with that type of device. So just for comparison, this is what a Saebo glove looks like. And you can see here the position of my fingers, wrist, and hand. And I'm not going into a lot of wrist extension. I can just, this is much closer to neutral, and I can just focus on moving at my fingers themselves, and I can have a very functional type of grasp here. Probably my favorite aspect of this device is that, as you can see, you have various bands that connect from the different joints here. So down from the DIP to PIP, the PIP even all the way down to the MP, and you have a component here also for the thumb, and you can swap out these bands, and you can add more resistance, you can have less resistance, you can have no resistance at all. So you can facilitate extension exactly at those components where you need that extension. And if you don't need that extension, you're allowing the patient just to use extension themselves. They can just use their own volitional movement. So you can really just facilitate where you need to facilitate, as opposed to having a very rigid type of device that will facilitate indiscriminately. Another thing we did was change up the environment, because we didn't want Mr. Kim to only learn one skill or one specific occupation. So as his therapist, I want you to think about what are some of the things that you would do to make sure that there's a transference of skill into other activities. Let's watch this video here. So eventually we bring Mr. Kim outside. And the reason for this is because I didn't want him to work on baseball all day long. I wanted him to work on other occupations. And one of his true occupations was gardening. So changing the environment or the activity, but still trying to utilize the same essential components of movement. You can see here that Mr. Kim's still having some difficulty. He's trying to grasp the soil and he's trying to release the soil. So once again, we bring it back to his normal movement, normal body mechanics. Maybe we can tap into tenodesis and try to get that wrist flexion in order to extend his fingers and see what we can do here. And one of the advantages of working outside and going to the gardening and having Mr. Kim play with the soil is that he is actually getting quite a bit of sensory feedback from the soil and also that sensory feedback from the environment. So, and this was really important because Mr. Kim could do really well in the clinic. He was actually reaching this point where his motor control and his coordination was getting significantly better in a very controlled environment while we were in the rehab gym. But once we brought him somewhere else, once we brought him outside, maybe he was at the gift shop, maybe he was walking across the street, he would become nervous and then he would start to freeze up and all his movements became much less fluid. So we had to make sure that he can acclimate to different environments, and hence why we bring him out here. Now he's working on the soil. You can see here combining this with the motor actions that we've been working on all this time, tenodesis, etc. Really trying to empower his entire system to relearn all of these components. Now, electrical stimulation, obviously one of the best, one of the most research interventions out there for upper motor neuron injuries, such as a stroke. But there's really different types of eSTIM programs out there, and not all of them are created equal. Some therapists consider all eSTIM programs to be FES or functional eSTIM, but truth be told, unless the person is actually working on something that's functional, it can't be classified as FES. And I see this way too often. A lot of therapists will have their patients on a program where they're placing electrodes on their wrist extensors or finger extensors, and they're trying to facilitate extension using their eSTIM device. And the patient is just sitting there watching their hand go up for 10 seconds and then hand go down for 10 seconds. And then it goes back up again for 10 seconds. And then it goes back down for 10 seconds. And I think you get the picture. So at that point, I kind of wonder, like, what is the therapist doing? Are they just watching the patient move their hand up and down? Are they getting a cup of coffee? It seems like this is something that could be assigned as a home program, maybe not so much to do while the person is at the clinic. So let's take a look at this video and see how we can optimize an eSTIM program. So my recommendation for any type of functional eSTIM program is to allow the patient to be in charge of the trigger. And what I mean by that is right now, the patient is using his own finger flexors in order to grasp this tennis ball. But in order to release, he's having some difficulty. So right now he's trying his own volitional movement. He's not able to do that. So he triggers the eStim device. He presses a button in order to activate that contraction. And now he's able to extend and release the ball. And now he's doing the same thing here. He's triggering the device in order to open up his hand, extend at the thumb, extend at the fingers in order to get a good grasp, using now his own strength, his own motor control to grab onto this tennis ball. And once again, now he's trying to volitionally extend his own fingers. He's not able to. He controls the device himself in order to do that. So rather than do a cyclical type of training where fingers or a hand goes up and down for 10 seconds at a time, give the patient control. And it doesn't necessarily have to be a triggered device such as this. If you're able to control the amplitude of the device, go from 0 to whatever in order to get that muscle contraction that you're looking for, if you're able to incorporate a functional activity with this, then you can make your eSIM program quite a bit more optimal for their motor recovery. So now we're seeing the same thing, but we increase the challenge by giving him a baseball, much larger diameter. He's using the device right now to extend and abduct that thumb, extend that second and third digit there, using his own flexors now, volitionally to grab onto that baseball. Beautiful grasp there. And he's having some difficulty releasing that ball, triggers that device to release it and let it go. So for Mr. Kim's home program, when it came to electrical stimulation, we actually lent him this device and he eventually paid out of pocket for one himself. This device here is called the Aviva Stim, which is a self-triggered machine. And once again, you don't necessarily need to have a device that has a trigger. It does make things quite a bit easier if you program it for the patient and they essentially just put the electrodes on themselves and they're able to turn on the machine and trigger the device themselves. But if you don't have a machine like this, you can once again use a device where you can control the amplitude, set it to 0 and to whatever number, and you can time it accordingly. And I gotta say that Mr. Kim was really an ideal patient because whatever he did in therapy, he would go home and he would practice it over and over and over again. So we would record our sessions so that he would have a record of essentially what he did and he would practice all of these things at home. And essentially, I didn't give him any guidelines in terms of doing this many repetitions or this many sets. I told him as much as you can with great repetition, with intensity. I want you to do as much as you can with that right hand. And that's what he did. And he used this eSIM device religiously with all these different activities at home in order to restore his motor control. This in addition to using that Saebo Flex, this in addition to positional training and whatever else that we've done in therapy thus far. Because Mr. Kim was so motivated to practice at home, we didn't waste time in therapy doing the same things over and over again. We can move on to different activities and grade up. We can challenge him with different environments and scenarios in order to work on motor planning and execution and coordination. Most importantly, we can try so many different interventions and we can quickly figure out what worked or what didn't work. So let's take a look at this next video here to see how we can grade up the various activities, to grade up the various components we've already worked on. So it's one thing to grasp a ball if it's directly in front of you and it's stationary. It's a whole nother challenge if you're trying to catch a ball, if it's moving in various directions. So what we're trying to do here is we're trying to increase the challenge by having Mr. Kim coordinate all of the different movements in his arm in order to effectively catch the ball. And you can see that he's actually doing a very good job here. He's able to use his first 3 digits in order to grab the ball. And he's essentially doing this 3-jaw chuck deep into the palm of his hand in order to effectively grasp it and hold onto it with a very firm grasp. Now getting it deeper into his hand into a true spherical type of grasp and strong flexors there in order to grasp it. Still having some trouble with release, but not too bad. Certainly not as bad as it was during his evaluation. So what we're going to notice here is that Mr. Kim is still having some difficulty with finger extension in order to release the ball. What he's trying to do here is he's just handing the ball over to the therapist instead of actually using his own finger extensors to release. And now it's one thing to cross midline in order to release the ball. And it's a whole nother story when you're going out into external rotation and abduction of the shoulder. And I'll explain why there's difficulty with movement there later on. Grabbing onto the ball, nice spherical grasp there, but still having difficulty with that finger extension, that thumb extension as well in order to release. And what I really want you to focus on here is take a look at his hand. He's not really trying to squeeze the ball out of his hand now. What he's really trying to do now instead is to relax the hand. And if you relax the hand, maybe you're not going to have too much active finger extension, but at the very least, your flexors are not going to be so dominant where the ball is going to be stuck in your hand. As long as you're able to relax the hand, there's a good chance that the ball can fall out as opposed to being squeezed out. So you're going to notice that Mr. Kim is wearing that tape once again, and this is dynamic tape. This is not kinesio tape. And we actually didn't provide any stretch on that tape. So there's no stretch, there's no pull, there's no resistance whatsoever. It's not bringing him into extension. What we really wanted to do here is just remind Mr. Kim that he has extensors in his arm. We wanted to provide him that sensory feedback. We actually didn't want to stretch him out. We didn't want him to compensate that way. We just essentially want to give him a tactile cue to remind him that, yes, you do have those finger extensors there, whether they're intrinsic or extrinsic, they're there. And hopefully we can tap into that from a sensory perspective. So before we move on to the next video, a couple of things I want to talk about first. Mr. Kim, once again, very dedicated patient. He was very much into his therapy program. He did a lot of mass practice at home. And when it came to his actual therapy sessions in terms of his frequency and duration, we didn't have him on the caseload for very long. I believe we had a total of 8 sessions with him, and that was essentially all we had. So we didn't want to burn through all of his sessions right away. We spread them far apart. So we did something new every single week. And he would practice at home for 1 or 2 weeks at a time, and then he would come back and we would work on something new during therapy. And we would just essentially review all the things that he was able to do or not able to do, and we would try to optimize our program from there. So this next video I'm about to play, this is his second to last session with us.
예. 제가 다 올게요.
So in this session, Mr. Kim is throwing the ball. And first, we are crossing midline. We're doing this as a warm-up because he's better able to move his hand and release his fingers into extension by crossing midline first. And now we have him throwing the ball forward. And really want you guys to focus on his wrist and also his finger movement here. So wrist very much close to neutral, and look at that finger extension in all the digits and comparing that to his finger extension on day one. So a couple of things I want to highlight here is, once again, Mr. Kim is wearing that dynamic tape. There's no stretch, there's no resistance there. It's not pulling him into any more finger extension, just using that as a tactile cue for him. And in terms of his upper extremity motion and movement that we're seeing here, he's able to get into some nice finger extension. His wrist is at neutral. You can see here that he's having no issues there with his shoulder or elbow. It's not going into any flexion there. We're not trying to utilize synergies. This is basically now functional training. We're allowing him to throw a baseball or a ball. Whatever his regular movement is going to be, that's what we wanted him to practice. So one of my favorite parts of this video is just looking at Mr. Kim's entire body. Look at his body mechanics, the way that he's positioning, the way that he's using his trunk and he's rotating, the way that he has one of his feet forward, the other one back. He's actually throwing this ball as if he's playing baseball. He's utilizing normal movement. He is a baseball player and he's tapping into that muscle memory that he's had for many years of playing baseball. And he's able to tap into that and regain some of the motor control in order to effectively release the ball in this very ideal, optimal, normal position. So before I continue on with Mr. Kim's story, I want to make sure we have a good understanding of positional training and utilizing synergies. And all I'm really doing here is very basic movement analysis. And I'm trying to learn how each of my patients move when they're in a certain position. So let's do some movement analysis right now. I'm going to play 2 videos of the same patient. And in this first video, the patient is going to be standing with his shoulder and elbow at 0 degrees. And in the second video, the patient is going to be sitting with his arms supported, very similar to what Mr. Kim showed us in his first session. So now that we watched the 2 videos, let's take a look at these positions. The first one is a very neutral position, neutral upper extremity where the shoulder is at 0 degrees, the elbow is at 0 degrees, and I'm basically trying to ask my patient to move his hand. And in the second video, we have the patient positioned in flexor synergy. This is much closer to flexor synergy than what I had Mr. Kim. This time we've added some external rotation of the shoulder. And just by doing that, you were able to see him move his fingers into flexion and extension where he was not able to do so when his shoulder and elbow were at 0 degrees. So why was he better able to move in this position, the fingers, versus just being in a neutral position? And once again, it's not about providing that proximal stability. This is about using synergies to help with that motion. So to clarify, flexor synergy looks like this. You have your shoulder in abduction and external rotation. Your scapula is retracted and also elevated. You have your elbow in flexion, your forearm in supination, and your wrists and your fingers are flexed. The opposite of flexor synergy is extensor synergy, and your shoulder is adducted and internally rotated. Your scapula is protracted and depressed. Your elbow is extended. Your forearm is pronated, and your wrists and fingers are extended. So when you're working with a patient who has a neurological injury, you're going to see some of them move much better when they're positioned in flexor synergy, or some of them may actually move much better when they're positioned in extensor synergy. Or in Mr. Kim's case, what we've learned is that if we position him in flexor synergy or extensor synergy, he moved really well in either one of these two synergistic positions. This is why I had Mr. Kim throwing the ball across midline first before he were to throw that ball forward, because throwing it across midline, I wanted to tap into a little bit of extensor synergy before he threw the ball forward normally. And because we had him do that and we had him practice that, he learned how to control his wrist extension and his finger extension at the same time. He didn't have to rely on tenodesis. So going back to tenodesis, you have a tendency to go into finger extension when your wrist is flexed, and you have a tendency for the opposite to go into finger flexion if your wrist is extended. But we didn't want Mr. Kim to get used to that. That's a very compensatory type of training that we were introducing to him. But basically, we showed him how to do that so that he can practice and his body can get used to his normal movements. He can get used to that range of motion that he had before. But we didn't want him to rely on tenodesis because, once again, very compensatory. We wanted him to learn how to isolate his movements. So we tapped into flexor synergy. We tapped into extensor synergy because we wanted him to learn how to move his wrists and fingers into flexion. And we also wanted him to learn how to move his wrists and fingers while he was in extension. But eventually, we didn't rely on synergies either. We brought him out of that and we had him throwing the ball forward. So once again, I'm going to pause this video here and just remind you of what it looked like. So crossing midline first, and the reason for this is because we're trying to have him practice his motions while he's in extensor synergy, trying to get him used to that wrist finger extension combination at the same time. But we didn't leave him here. We eventually brought him to a more natural position where he's throwing the ball forward. So pausing the video here, I want to highlight that there's nothing about his upper extremity movement that is purely flexor synergy or purely extensor synergy. Some might say that we're combining synergies. Some might say that we've now progressed beyond that and we're moving into normal movement. Because if you look at this, he's not in pure flexor, he's not in pure extensor. He's basically just throwing the ball directly in front of him. His shoulder is flexed to 90 degrees, his forearm is pronated, his wrist is very much neutral, his fingers are going into some flexion and extension. There's a combination of that as he's throwing and releasing the ball. It's not a pure extension like this because that's not how you throw a ball, but you'll throw a ball more like this and you'll have a little bit of flexion as well. So combination of that with your MPs being extended, this is just a very normal types of movement. So I love pausing the video here because you can see how natural his movement is. And I love this because his elbow is fully extended, but more importantly, look at his wrist. His wrist is perfectly neutral. And with that neutral wrist, he's able to release the ball and get his hand in a more functional position. And that's really quite a challenge for our therapists out there who've worked with neurological clients for a while. You're going to notice that it's very difficult to get those fingers to actively move without that wrist being in the way, without that wrist compensating. So we're able to actually get his wrist into a neutral position and just relying on his fingers to do the work here. And if you notice what's going on is his MPs are extended. He has some slight flexion at his fingertips, but once again, that's very normal movement. You can see that this is essentially in an intrinsic plus position. His intrinsic muscles are working, and that's really a good thing that we were trying to accomplish here. So unfortunately, not a lot of therapists know about or care about positional training or synergistic training. And sometimes this is referred to as brunch room therapy, but it's not really utilized because it's criticized for number one, being outdated, and number two, for lacking strong evidence. And it's really hard to argue with that because there's essentially no systematic reviews or meta-analyses that really look at Brunstrom therapy as a type of intervention. Yes, we have the Brunstrom stages that are commonly used, but the intervention itself, not so much. The most recent RCT that you might find is this one published in 2012, where they found that Brunstrom is more effective than a motor relearning program for rehabilitating the hand in chronic stroke patients. However, other than that, not a whole lot of recent articles out there. And a big part of why synergistic training isn't very common these days is because of the Bobath NDT approach. And this tends to dominate neurorehabilitation. When it comes to NDT, it's really about inhibiting those abnormal patterns of movement and really trying to facilitate more normal movement. So when it comes to synergies or reflexes or tenodesis, really the theory is they should not be used because hypothetically, they can become more dominant versus your normal pathways. So instead of having normal movements, you're going to start to see more abnormal movement. But what I really want to highlight here is that this is theoretical, because out of the thousands and thousands of neuro patients that I've treated, and we've done synergistic training or positional training, no one has ever gotten stuck in this position or in this position. Because when it comes to therapy, I don't keep them in these positions because it's not practical and it's not functional. I don't tell my clients, well, you're going to walk around all day doing this in order to grab something. You're never going to be able to grab something because your arm is way up here. We start here because they learn how to move there. We work on their coordination. We work on their range of motion. We work on even their circulation, just getting the feel of how their hand used to move. And we transition them out of these positions into something more practical for everyday functional use. So please don't get me wrong. I love NDT. I love handling techniques. However, I believe it has its time and place and purpose as well. But it's almost hypocritical to say that don't use synergistic training, don't use positional training because the evidence is poor, when on the other side, the evidence for NDT is also poor, or at the very least, it's lacking. In systematic reviews, they found that there's no evidence for the superiority of NDT when it comes to upper extremity and lower extremity, motor control, dexterity, mobility, ADLs, and so on and so forth. So just because something is not necessarily evidence-based or doesn't have that high-level evidence doesn't necessarily mean that you should rule it out. So let's bring this back to a mixed method approach. In a systematic review of 21 trials, researchers found that a mix of different approaches is more effective than one single approach. In a follow-up systematic review of 96 studies, there was no evidence that any one approach is more effective than others. Therefore, it's recommended that rehab should not be limited to a single approach. So I just want to clarify, because there's nothing that I said there that says don't use NDT or don't use synergistic training. Basically, what it's trying to say here is don't use it exclusively. So once again, I'm not encouraging you to do one thing versus another. I'm not saying that your treatment has to be dominated by NDT or synergies. You can try both. It's not against the law to marry the two together in order to optimize your program. So let's review Mr. Kim's plan of care. You can try eStim. You can try orthotic devices. You can try them at different points in time and see how your patient is able to progress. Or if they're not progressing for that moment, you can put it on hold and you can try it at another time. You don't have to be a robot and follow one set protocol, because that protocol, the reality is it doesn't exist. And our patients are dynamic and our therapy is dynamic. And that's really the beauty of using a mixed method approach. It allows you to use your experience, your clinical judgment to determine the best course of action. It allows you to be a therapist. And as therapists, our job isn't to have that one perfect answer, but to be flexible enough to find different solutions in order to optimize that program. So in my humble personal opinion, as long as you achieve that outcome, whatever it is that your patient wants to do, how you actually get there is secondary. Just get there. Speaking of outcomes, let's wrap up Mr. Kim's story. And I have very fond memories of this story because this was the last patient I had working in this particular facility. And I had just accepted a new position to become a professor of OT at the University of Southern California. And it just so happened that my first day at my new job was Mr. Kim's last day in therapy. And throughout the day, I was really wondering, was this the right decision to leave this outpatient practice, which I pioneered and I started, to go into full-time academia? And as I wrestled with those feelings, the therapist now working with Mr. Kim at the time, he calls me up and he says, "Hey, Mike, guess what Mr. Kim did today?" And I'm thinking, well, it's his last session. He's probably getting ready for discharge. The last time he was throwing a rubber ball, he's probably throwing a baseball now. He's probably fine-tuning whatever he needs to work on. And the therapist tells me, yes, that's exactly what it is. But he also played baseball with the neurologist. And not like just a throw and catch game of baseball, but a full-blown game of baseball with teams and players. And Mr. Kim was the pitcher and he was striking people out left and right. And I had all kinds of feelings like, oh my gosh, did I make a mistake going into academia? Because now I'm not going to see cases like this where my patient are going to start playing baseball. But a number of years later, I think I made the right decision because I can't tell you now how many former students have their own success stories just like this. And my point here is if we empower our therapists, if we allow them to use their own clinical reasoning, to not be so rigid in protocols and allow them to find different ways to do things, then they can get their patients to play baseball or to do something so much more meaningful. So thank you for this opportunity to share this information with you. I hope you found it inspiring. If you'd like to learn more, please visit us at the Neurospecialist Institute. Our website is up here, www.neurospecialist.org. We have a certification course for OTs and PTs and assistants and other healthcare professionals to become a certified neurospecialist or CNS. And you can also learn more about Saebo at their website, www.saebo.com, and take a look at their devices. You may encounter something you haven't seen before that could be a great benefit to your patient. Once again, we highly encourage you to be open to new and different things. Please share them with us whenever you have a chance. Keep in touch because I really want to hear about your own amazing stories. Thank you very much.